Hi, Dr. Miguel. This is Dr. Zia. I am actually moderating the session. This is afternoon in Pakistan. I suppose this is morning there, early morning.
That is correct. It's
Yeah,
5 in the morning here.
yeah. We have a good audience here. There are three chairs of this session: Dr. Khalid Makhdoomi, Dr. Ilyas Sadek, and Dr. Iram Naz. And the mic is to you, and you can start. You have 15 minutes, and then we have a small 5 minutes discussion with you. Yeah,
Very well, thank you. Are you able to see my slides? I'm sharing my screen.
yeah, very clear. Thank you.
Very well. Good morning, everybody. It's a true honor to be here, sharing with you guys. Obviously, a little bit of a time difference, but I'm happy to be here. And I will be talking to you about a project that I've been involved now, I want to say over 5 years. When I got to the city of Houston, the prevalence of renal insufficiency here in diabetes is incredibly high, specifically for Hispanic and the Black community. And was having a lot of trouble at the beginning trying to find an option. Today, this is how our group works. I'm part of a private group that is a limb preservation group that covers the Houston Medical Center. So we work out of all major hospitals: Memorial Hermann, Houston Methodist, Baylor College of Medicine. And what you see here is a grid essentially made by the Wi-Fi score on the left-hand side on the Y, and the medial artery calcification of the pedal vessels on the X. So you have low max scores to high max scores, and then Wi-Fi stages 1 all the way up to 4. When there is low max scores, we believe those patients are really good candidates for arterial reconstructions. And of course, based on some of the novel data from the best CLI, we are strong advocates that using a greater saphenous vein in a single segment is a great opportunity, especially for patients that have high stage 3 and 4 Wi-Fi scores, because patency will probably help with the long-term management of these patients. Now, when these patients have high max scores, high pedal calcification scores, we don't believe that these procedures should be the first option. And most data shows that arterial, endo, and open reconstructions lead to high prevalence of repeat interventions and unplanned repeat podiatric interventions, meaning multiple amputations leading eventually to major adverse limb events. So we believe that these patients probably all deserve some degree of arterialization procedure, be it by an open or an endovascular procedure. One of the things that we do believe is that the model at the core should be an unbiased vascular group, meaning unbiased in the sense that who cares if it's endo or open? It's about what's best for the patient, not what's best for the doctor. And the leader of the vascular group has to have all these other people around them helping get the patient through this procedure. And we like to work with the podiatrist. This is very different around the world. But in the US, we have surgical podiatrists that are really good at reconstructing the foot, at doing tendon advances, at lengthening Achilles tendons, at doing reconstructions and skin grafts. And so this group essentially is the core group of the people. The ultrasound technologist is incredibly important too. And then nursing staff and wound care staff follow the patient. This is our grid for the evaluation of what we consider the no option CLTI patient, meaning the patient that will probably do better with an arterialization. High frailty scores, high Wi-Fi staging, poor conduit alternative, high medial artery calcification scores, and then limited access to healthcare and support networks. These are the patients that normally we have a conundrum with. We don't know exactly what the best alternative is, and we does believe now that probably an arterialization should be considered primarily. This is a Miguel sign on a patient with an X-ray, and it is one of the easiest ways to determine MAC pedal anatomy. We published 2 years ago in the Journal of Endovascular Therapy. The primary author is Roberto Ferraresi, but there's a very beautiful paper there that showcases the importance of MAC score and how it negatively impacts the results of these patients. 2-view X-ray, AP and lateral, and you can determine high calcium content, at which point you probably should consider, in the setting of poor pedal anatomy, an alternative conduit to get blood down to the foot. When we see our patients, we do these 1-hour protocols in which the patient gets an advanced mapping characterization of disease. We also do ultrasonic assessment of the calcification scores, and we determine pedal artery anatomy, and then we also look at all the veins and conduits. So this is what a normal ultrasound looks like in our facility. It's a very good map. It shows essentially everything you need to plan a case. We don't do advanced imaging like MRIs or CTAs. We just do a very good ultrasound duplex, triplex. As you see here in this patient, there seems to be very disease below the knee and specifically below the ankle pattern. This patient looks like it could be a high MAC score patient. There is no good landing zone for a potential arterial reconstruction, but already they're telling me that the lateral plantar vein measures 3 millimeters, that I have a high MAC score here on the X-ray, and that I also have good conduit if I want to do the arterialization with the saphenous vein or the arterialization with the endovascular stenting approach. Pedal anatomy can be very detailed, and we really get a lot of information that allows us to determine what the patient should have. So our first approach here is always looking at the anatomy. When you're doing an arterialization, the first thing that we've learned is never disrupt whatever's already there. So on the left-hand side, you see disease of the posterior tibial, essentially with maybe some flow in the anterior tibial and into the circuit of the foot. In this case, if we are going to arterialize, placing a stent into the PTA and then dropping it all the way into the lateral plantar vein is probably the best idea, because you are not affecting any of the baseline arterial flow. In this other image, what you see is a posterior tibial artery that seems to be the main vessel to the foot. In this scenario, if I put a stent from the posterior tibial artery into the posterior tibial vein, I would essentially be creating acute ischemia by removing whatever flow is going into the foot through the PTA. So the best case scenario here is possibly just using the saphenous vein, creating a bypass to the popliteal, and then inside to removing the valves so that the flow goes into the medial marginal vein and into the top of the foot. I'll show you a couple of angiograms to further demonstrate. This is an angiogram where the posterior tibial artery is the main vessel. Even though it's horrible, even though it's small, that is what's keeping that foot alive. So anything you do to potentially affect the flow of this artery is going to make things worse and very fast. So this is a patient where an open hybrid superficial arterialization is probably the best option. Incision is made proximately, the VSV is swung down, and then we place a distal sheath into the medial marginal vein, and then allowing the valvulotome to come all the way up by ultrasound guidance, and then we create a arterialization of the superficial venous system. We call it hybrid because sometimes there are perforators that are not easily accessible with surgery, so we will coil them when we're doing this procedure. This is the other case. This is a case that has perfect anatomy for an endovascular arterialization. You have a posterior tibial stump that goes nowhere. I can very easily jump from this to the vein and place a stent to take all the flow down into the lateral plantar vein and get into the heel segment. So endo would be ideally. In order to do that, we usually get access from the artery and from the vein. The access is done in the lateral plantar vein. We align a catheter from the vein and the artery. We cross and essentially wire the vein through the foot, so you get a through and through. We lyse the valves, and when we place PTFE stents going from the artery all the way down into the foot, into the vein. So on the left-hand side, you're going to see an angiogram of a hybrid superficial. The inflow is the GSV into the medial marginal vein, and then through the perforators of the foot into the deep system. The outflow is the deep venous system. On the right-hand side, I'm going to show you the opposite. It's an endovascular inflow through the endovascular posterior tibial vein, and then all the way out through the superficial venous system, including outflow through the greater saphenous vein, as you can see here in the late phase. It's right there. We put our experience together. I invite you also to look at this paper. We showed some of our results with endo and open. And essentially, clinically speaking, the results are the same. These are met with over 2/3 of the patient leading on to limb preservation and limb salvage, functional limb salvage with very early ambulation dates, because we don't do any foot reconstruction till approximately 4 to 6 weeks after the arterialization. So we really push these patients to rehabilitate. Of course, endovascular has less patency, but this wasn't a problem given the fact that the arterialization seems to need to be open for no longer than about 6 months. And usually that is enough to get the patient healed and into remission. And even the arterialization going down, we have noticed that there is a significant amount of neoangiogenesis despite the occlusion that keeps the patient better perfused than at the baseline procedure. The PROMISE 2 study is a PROMISE that was infused, or the study was the company that put this study together was a company called LymphFlow. That company was now recently acquired by a bigger company called Inari Medical. And LymphFlow is the one that owned and developed the technology of the endovascular arterialization. So this study in the US that led to the FDA approval in September last year was done on dialysis in Rutherford, up to Rutherford 6 patients, with no option confirmed by independent review committee. The limb preservation in this group was up to 76%, and the amputation-free survival on these patients was 66%. That was shown at 180 and then at 360 days. As I said before, in September of 2023, this device was formally approved for such revascularization techniques, and now you can commercially find it here. I'll show you a quick case to finalize my presentation. This is a patient of mine that was part of the PROMISE 2 study. She's a 69-year-old female at Rutherford 5, had a stable wound on her second toe, and was not a candidate for an open repair. She didn't have a good conduit. We had attempted multiple endovascular procedures, and she had recurrent pain and ischemia to that forefoot. So we finally elected that we wanted to do an arterialization. As you see here, the patient did not have a good posterior tibial. Most everything came from an anterior tibial, and everything at the foot was just small, athletic, fine collaterals. A reminder that the pedal venous axis needs to be distal in the lateral plantar vein, because there are 2 or 3 valves in the foot that are very hard to cross. So if you do the axis at the malleolus level, then you're going to have a lot of trouble trying to break the valves into the foot. So it's always good to get access as distal as possible. Here you're showing a longitudinal approach of the lateral plantar vein of the foot, and then a venogram to follow, showing the very complex array of veins in the foot in connection to the multiple systems, including deep and superficial here with this very thin, small saphenous vein this patient has. Once you get that in, you can create crossing. Of course, this is the lympho system. The crossing essentially is done into a basket, and then a wire is trapped from the bottom. So the crossing system is coming from the artery, and the basket is in the vein. You can envision that this can be done off the shelf too, with using snares and maybe a crossing device like the Outback catheter that already exists in the market for re-entry in femoral segments. To follow balloon angioplasty, valve lysis, and the last part is placing stent grafts. These are the stent grafts of the device that are tapered for appropriate sizing at the arterial level in the posterior tibial artery, but you can certainly accommodate a 5 millimeter biobund without any trouble, again, if you want to consider doing an off-the-shelf solution. This is what a completion angiogram would look like. It is a nice posterior tibial artery to posterior tibial vein stenting, ending in the lateral plantar vein, and showing that there is flow into the foot, as you can see here in the distal projection. Now, this procedure at this point needs to mature. We know that the transcutaneous oxygen pressures elevate appropriately so at 4 to 6 weeks. And so we normally don't touch the patient for a few days. We let unless there's severe infection or pain, these patients are just managed with wound care, and we try to stop. We defer for about a month and a half the reconstructive procedure. This is the progression of this patient. As you can see, by 2 months, she started sloughing the ischemic tissue. At 4 months, you could even think that this was just going to fall off and we were going to have a little small ulcer to manage, but the patient had problems with her socks, was constantly yanking at this, and got to a point where she felt there was too much pain to manage. So we did a small toe amputation. We've learned to leave everything open. We don't close anything primarily with arterializations, and they did really well towards the end. This is actually 2 and actually 3 years out. She's been still patent, which is surprising because the normality is that these would occlude at about 6 months to a year. And if they occlude and the patient is in remission, I would absolutely do nothing. I would let it be, because chances are that her ABI after occlusion is going to be much higher than her baseline ABI, again, based on some of the molecular things that happen. So in order to do this, you need a good team. You need endo skills. You need open skills. You need good reconstructive foot surgery, and you need to work as a team. I think unmet need still is to continue working with the international working group. We have created great alliances with some of our colleagues in Italy and now in Latin America. And obviously we would definitely welcome having some of our colleagues from Pakistan also joining this group and this effort. Continue the quest for understanding patient selection, limiting the indications so that this is not flawed and attempted to do in situations where a good pedal bypass would be the perfect solution. This is absolutely not that intention. You have to find the right indication of a no-option patient. We want to understand molecular changes, what's happening in the foot, improve the technique acutely, and improve follow-up. Thank you very, very much. That is my email. If there's anything I could do to anybody and help in any way, shape, or form, I appreciate the invitation. Thank you very much.
Dr. Miguel, can you hear me? Yeah, it was so nice when I visited for this complex peripheral intervention in Chicago, and I said, there are so many endovascular technique requiring inventory, which would be difficult to get, very quickly in Pakistan. So this deep venous arterialization, especially for no option, which means you cannot do the open bypass and you cannot use available atherectomy or advanced endovascular options. So that's why I introduced this to organizer here, and thank you so much for presenting this. I will ask if there is any question from the audience, please.
Can I ask one question?
Yes.
Dr. Baker, the people who advocate this procedure, arterialization of the veins, they say that the veins less than 2 millimeter in size, they don't either have the valves or the valves are insignificant. What are your views about it?
I think that is a very astute observation. The smaller the veins, they may be. I think they're easier to break. I don't know that they're insignificant in the sense that one of the major issues we have right now is that when we do the arterialization, the metatarsal veins are protected from the deep loop of the venous arterialization by valves. And those valves in the metatarsal veins are relatively hard to break. It may just be a technical problem that we don't have the appropriate devices. But what happens with time is that the venous loop extends. You have arterial flow, so the venous segment will dilate, and then these valves become incompetent, and then it recruits further and further. And that's why these patients get better every day that goes on, because some of the new veins are recruited. And that happens in time. But it takes 4 or 6 weeks for that process to happen. And the problem in that is that a lot of patients that may just have a small ischemic ulcer may actually convert to a full-blown 4-foot ischemia. And they end up with a TMA, which, it's okay in the sense that you are doing limb salvage and that you didn't have any other option. But it is a problem, even though they may be small, they are pesky and they take a lot of time to open up and recruit. I think that we should get better at dealing with them at the baseline procedure.
So, do you recommend that if I don't have an arrangement for breaking the valves, I should still do this procedure?
I think you can. There are some ways in which you can rip the valves. One is using cutting balloons at low atmosphere and sliding the cutting balloon through the valves. You can also use a catheter in combination with a wire. So using 2 wires, one over the wire catheter and a secondary wire that comes on the side, to use it almost as a scissor. So there are some, I work in Latin America. I do a lot of work in developing countries in Latin America. And I have made some very creative ways to rip valves. So I wouldn't necessarily stop you from doing it. I think that there are creative ways in which you could do it, despite not having necessarily the perfect valvulotome.
Okay. Dr. Baker, can I ask you a question about the patency of this system? Obviously, we as vascular surgeons know that if there is no outflow, the graft or the stent is not going to work for long. And in cases where the valves are resistant to be plastied or broken, and as you said, that it takes about 6 weeks for all the circuit to open up, then what is the failure rate of these stents in your experience?
So the majority of these stents will fail. I would say that at 1 year, the majority of these endografts are probably down. But as also the point that I was trying to make earlier is that usually if you can keep these stents open for anywhere from 6 to 9 months, and for that you may need to do assisted primary or secondary patency interventions, that what happens then is that if the foot is essentially in remission and the arterialization circuit goes down, the deep venous system of the foot still has magically enough, or hard to believe, but I know it is. I know this for a fact because we look at these patients closely. There are still arterial waveforms in these veins, despite the main conduit being done. What we believe is that there's probably microfistulae that gets open somehow, because despite the occlusion, you can still have arterial waveforms in the foot, in the forefoot, in areas where normally before you wouldn't have. And this is something we're trying to now investigate with MRI studies to understand what exactly is what happens. But when you see these patients, it's almost like a new network of collateral pathways has been reinvented in the foot. And on angiography, like late angiography, you will find that there are veins that act as arteries, and then they recruit also probably hibernating small vessels in the foot. And so it's pretty impressive. So you don't necessarily go down, let's say if you started at an ABI of 0.1 and the arterialization takes you to an ABI of 0.9, when it goes down, you may end up with an ABI of 0.5. And so we don't understand exactly why that happens, but it is something that happens.
Hello, doctor. First of all, your valuable insight regarding this arterialization of deep venous system. I just have one question. Is there any clear-cut contraindication or relative contraindication, like if patient have venous insufficiency, or do you have any patient having already venous insufficiency, and you did also having arterial, and you did this procedure? Then any improvement in venous symptoms or worsening the symptoms? Is there any experience you have? Thank you.
Yeah, that's a very good question. The main contraindication that we've found is an insufficient pedal venous system, and we believe that what we find is that the veins are athletic, the veins are very small, very tortuous, and very thick. And our hypothesis for this is that there's probably a lot of subclinical DVTs that happen in the plantar vein that never really get picked up. And so it's almost like you're looking at post-thrombotic veins. And so what happens in those situations is you have very limited wire navigability, and that makes it technically really difficult to do the procedure. It's full of synechia. You can't really dilate the veins. You can't really advance anything. You can't put a stent through it. So those cases are the ones where I normally would stop the procedure. And we realize that now more so with ultrasound. But sometimes you get to the point where you do the venogram and you just realize it's this horrible, athletic, and, small system. And then at that point, I normally just stop the procedure. As for the second part of the question, where if there is some symptoms from the venous congestion that you may create, the answer is yes. Actually, some patients will develop hyperpigmentation of the medial aspect of the skin in the legs, almost like a venous hypertension from severe reflux. But that usually is managed conservatively, and they respond very well to compression garments, actually.
Yeah, thank you, Dr. Miguel. This was really a great talk and a very great discussion. We wish we had more time and this is really interesting topic. Thank you so much. We will continue with rest of our session. We have small
Thank you.
walk.
Bye-bye.
And if you want to join, you can join. And after 10 minutes, we will be back again. Thank you. So, there are two tasks for us because we want some stretching. So we'll go from this hall to that hall and then come back again and not to deviate. Then So we are starting back after this walk. Yeah. May I request the chairs to seated Dr. Khalid Makhdoomi, Dr. Iram Naz, and Dr. Ilyas Sadiq. So please seated on the chairs. So one very important announcement. All fellows and the members are invited in the dinner. And please collect your coupon if you do not have the coupon for today's dinner from the desk, registration desk. From Masood, you can get it. So it is very important. All fellows who are here are also invited in that dinner. So we resume our session, which is the session 6. It is 8 o'clock? No, neither. 7 o'clock sharp, we are going to start the dinner. So our next speaker is Dr. Ahsin Manzoor. Dr. Ahsin Manzoor Bhatti is our next speaker. Yeah.
Bismillahirrahmanirrahim. First of all, it's a moment of great pleasure for me to actually present here in the first conference of Pakistan Society of Vascular, in the first conference of Pakistan Society of Vascular Surgery. Now, it has been a dream to organize this event, and actually with a lot of effort and difficulty, all the vascular surgeons of Pakistan have actually worked toward organizing this event, and thank God, Alhamdulillah, it is going great so far, and I hope the next day is going to be as exciting as today. So thank you very much for coming, and thank you very much for attending this conference. I am Ahsin Manzoor Bhatti. I'm a vascular surgeon working at CMH Rawalpindi. So the topic of my presentation is non-atherosclerotic occlusive disease of the lower extremity. Now, it's a very lengthy topic, and I know that it has been almost 7 hours that you are sitting here and listening to difficult topics and complex scientific data. So I will try to quickly go through my presentation, although it's a bit long, but I'll try to reduce it to the important aspects. So there are two types of images in my presentation. Some of them are my own, and which I have labeled as AMB, and rest of them are I have actually borrowed from the internet. So we all have seen and managed the arterial patient. A typical arteriopath is a middle-aged man with possibly major lower limb amputation, gangrene of toes, and maybe he's a smoker and has some other risk factors as well. We are okay with that, but then we start, but if we find a patient which is a bit abnormal, I mean in terms of presentation, then we start scratching our head what to do. For example, if we get a patient who's a young patient, smoker with gangrenous toe, and he hasn't got any other risk factors. Or there is a middle-aged male hypertensive with gangrene of toes and fingertips. Or sometimes we can get a young man with calf claudication and there are no risk factors. So what I'm going to do is I'm going to discuss few of these relatively uncommon conditions which can present with lower limb ischemic symptoms. And they would be Berger's disease, popliteal artery entrapment syndrome, fibromuscular dysplasia, vasculitis, and some other rare causes of lower limb ischemia. Starting with Berger's disease, this usually presents as usually a young male who's smoker and has got ischemic ulceration of toes. The prevalence of Berger's disease is variable throughout the world, but it is more common in our part of the world and also in Israel. The typical features of, the bit of historical background. It was first described in 1879, but later on Leo Berger actually used the term thromboangiitis obliterans for this condition, and later on this disease was named after Berger. Smoking is the main risk factor, and this leads to immune-mediated injury in a population who is genetically predisposed, usually living in lower socioeconomic condition. There is some risk with the oral infections, especially rickettsial infections. If you look at the histopathology, there is thrombosis of the arteries and also intense inflammation in the intima. As far as the patient's characteristic is concerned, the age of onset and age of diagnosis is usually relatively young, between 29 to 42 years of age. And the age of hospital admission is around 42 years on average. Predominantly, it is in males. 3/4 of the population is male. The main risk factor is smoking in any form, and there is also some family history. Patient usually present with either intermittent claudication or rest pain. Sometimes the patient can present with migratory thrombophlebitis, Raynaud's phenomena, or some sensory findings. Mostly this is present in the lower extremities, but sometimes upper extremities are also affected. Now, how to diagnose Berger's disease? Typically, the Berger's disease patients are young smokers with peripheral arterial disease without any atherosclerosis or diabetes. Once you start evaluating these patients, you have to take detailed history and examine all the pulses, take the ABPIs and segmental pressure, look for superficial thrombophlebitis, and also assess his sensory system as well. Duplex scan reveals monophasic waveform pattern in the collaterals in a typical corkscrew-shaped collateral pattern, and this can also be seen in CT or NCT or DSA. There's a long list of investigation which we need to do to rule out other causes. I'll come back to it later on. There are some other conditions which can mimic Buerger's disease, and these are cholesterol embolism syndrome and symmetrical peripheral gangrene. The main treatment is smoking cessation, and this is the single most important step. All forms of smoking should be stopped. Even no nicotine replacement should be there. Now, but stopping smoking may not necessarily prevent major amputation if this disease presents at a stage of critical limb-threatening ischemia. In addition to that, exercise training, trigger avoidance can be tried, and some pharmacological treatment have also proven to be of some benefit. Surgery is limited to either lumbar or thoracic sympathectomy. If the anatomy permits, then distal surgical revascularization should be done. There are some reports from India about pedicle to mental graft, and distal venous arterialization has recently been shown to be of benefit in these patients. Now, these intervention procedures are of experimental nature, and they may prove beneficial in future. Another type of patient which can present to us with lower limb ischemia is somewhat like this. This is a 53-year-old lady with disabling left leg claudication along with hypertension, treated by oral medication. Physical examination reveals a pulsating mass in the lower abdomen, normal pulses over the femoral artery, and a bilateral pulsating mass on the popliteal artery with no pulsation over the left pedal artery. Now, these are the patients with fibromuscular dysplasia. You must suspect fibromuscular dysplasia in hypertensives and in patients with any aneurysm at odd places. This is the finding of CT angio. You can see here that the string of bead appearance in the arteries, and maybe some of them are a little bit dilated as well. This is another patient of fibromuscular dysplasia presenting with acute low backache, and if you do the CT, you will find that there are some dissection in the iliac arteries. Fibromuscular dysplasia is a systemic disease. The most common site is the renal artery, followed by carotid artery, but it can be present in the arteries of the lower limb as well. Another important and quite confusing group of patients is the patients with vasculitis. Now, typically these patients present, they have some other systemic problem like hypertension, and they might have some joint pains as well. And they can present with a history of Raynaud's phenomena previously, and then at some stage they present with digital gangrene or some ischemic ulceration in other parts of the body. So these are the patients who need extensive workup. This is a broad classification of vasculitis. I'm sure you can't see it, but it's very confusing, and I think I always find difficult to remember these classification. And but what we need to do is we need to recognize how to differentiate vasculitis from typical atherosclerotic patients. So that is I think should be the goal of the patient vascular surgeons. There is no single presentation of patient with vasculitis, but large vessel vasculitis like Takayasu's or giant cell arteritis can present with limb claudication, vascular bruit, asymmetrical blood pressures, and absence of pulses in the limbs. Medium vessel vasculitis can present with cutaneous nodules and ulcers, livedo reticularis, digital gangrene, and mononeuritis multiplex or renovascular hypertension. Whereas small vessel vasculitis can present with palpable purpura, pulmonary renal syndromes, arterial skin rashes, and scleritis. Now, there is a large group of vasculitis associated with connective tissue disorders. The most common connective tissue disorders associated with vasculitis and digital gangrene is systemic sclerosis, followed by mixed connective tissue disease, then SLE, rheumatoid arthritis, associated vasculitis, ANCA vasculitis, and undifferentiated vasculitis. These are in the descending order of association. Now, how to differentiate between vasculitis and atherosclerosis? In a patient with vasculitis, there is no evidence of calcification or atherosclerosis in the proximal vessels. And there can be some skin findings like palpable pulpura or ulcers, livedo reticularis in patient with vasculitis. And the imaging studies can confirm these findings in the proximal vessels. Vasculitis have raised inflammatory markers, and vasculitic screen may be positive. There is a long list of investigation that we need to do to actually diagnose a case of vasculitis. It's very difficult to actually remember that, but there is a nice flow diagram. There is an algorithm which we can actually find here, and you start with doing an antinuclear antibody, which can either be negative or positive. If it is positive and if there is skin or joint involvement, then do these tests. And if they are positive, then you might actually consider the diagnosis of SLE. Or if there is no skin or joint involvement, then either if there is dry eye or mouth, then possible of Sjogren's syndrome can be there, and you need to do all these tests. Or if there is a Raynaud's phenomena, then consider connective tissue disorders and do all this battery of tests, and which can lead to diagnosis of connective tissue disorders. But I think the best would be to actually refer the patient to rheumatologist. Now, histopathological examination can confirm the diagnosis of vasculitis. So another type of patient now this is a patient, 27 years old male, who previously asymptomatic and healthy, presented to the emergency room with a 20 days history of sudden pain in the left lower limb, pallor, and pallor of foot. Now, patient did not have any other problem. This is a patient in which we must consider popliteal artery entrapment syndrome. He's a young patient, no previous history, no atherosclerosis, no evidence of vasculitis. Now we must consider that. Now, since that I'm short of time, so I'll quickly explain the types of popliteal artery syndrome. There are 6 types, and I'm sure you all know these. And the 6th one is functional hypertrophy, or especially lateral for hypertrophy or lateral attachment of medial head of gastrocnemius muscle. Clinical features of popliteal artery entrapment depends upon the extent of arterial involvement, whether the artery is damaged or not, and it is possible that these patients are completely asymptomatic. In severe cases, it can lead to thrombosis of the vessels. The diagnosis of popliteal artery entrapment requires higher index of suspicion based on clinical presentation and risk factors. Duplex ultrasound can be diagnostic if we do the dynamic test with plantar flexion. We can further investigate these patients with CT and MRI, and MRI can actually elaborate the anatomy of any abnormal attachment of gastrocnemius muscle or popliteal artery. Angiography can be useful in these patients as well. Now, this is a broad treatment options for popliteal artery entrapment syndrome. I'll just skip that. Another differential diagnosis is a patient adventitial cystic disease of the popliteal artery, and in this condition there are some cystic there are cysts attached to the popliteal artery, which can lead to compression and sometimes even thrombosis of the popliteal vessels. I think I'll stop here. If there are any questions, I will be happy to answer. Thank you very much.
So our next talk is Dr. Khalid Makhdoomi. Yeah, Ajay.
Thank you very much, Zia, and congratulations to the whole society for organizing this excellent meeting. And I see that inshallah it will grow over the years, because if you have that many people in a last session, then that means that they are interested in vascular surgery. Right, so the topic Zia gave me was open versus endovascular therapy in infant coronary arterial disease in view of the latest two level 1 evidence, the best CLI and Basel 2. So I'll go through these quickly, and part of it has already been discussed earlier. So I'll go through what is the chronic limb-threatening ischemia, which was previously called critical limb ischemia. It's one of the severest form of peripheral arterial disease. It presents, as we know, with ischemic rest pain, and with or without gangrene or any tissue loss, let me say. PAD is increasing, and PAD and CLTI are increasing at an alarming rate globally, and that is mainly due to the diabetes and the end-stage renal disease and increase in aging population. And currently we have more than 200 million people suffering from CLTI in the world, and with PAD, and about 25 million are suffering from CLTI. Obviously, this number of PAD is a huge burden on healthcare economy anywhere in the world, and what to say about our economy here in Pakistan, where people have to pay for all these treatments. Obviously, there is no medical therapy, and unless the leg is revascularized, these patients are going to lose their legs. And this is where it is very, very important to make sure that we can save these legs so that the patients can keep their livelihood. Our primary goal should be to relieve pain, heal the tissues, and to preserve the limb. In the last 5-6 decades, the gold standard of treatment for CLTI was surgical intervention and bypass. But with the advent of endovascular surgery in the last 2 decades, which has become increasingly utilized, and with the technological advances in the endovascular field, most of the vascular surgeons have taken this as endo-first approach with all these patients with CLTI. But there was no level 1 evidence, and all were anecdotal. Some societies have made given some ideas as to how we should be treating these, but there was no level 1 evidence, all the weak evidence. So treatment of the CLTI was marked with a high degree of equipoise. There was a substantial treatment variability, and it was biased from the point of view of the person who is treating these patients. So the first level 1 trial, which was published, was in December 2005, which was Basel 1, which actually it was more so to be more so treated the below the inguinal and above the popliteal arteries. 75% of the patients who were recruited had the treatment in the thigh, and only 25% had below knee treatment for the patients. And they looked at the amputation-free survival, and they looked at after 5 years, and they actually suggested that patients should be treated with CLTI. Patients should be treated with the vein first approach rather than endovascular. So people continue to do the bypasses with the confidence that we have a level 1 evidence. Then after 17 years, Best CLI published their results in December 22, and they also confirmed the same thing, that they divided their patients into 2 cohorts, one which have a single segment long saphenous vein, and the others who had didn't have a single segment long saphenous vein, and other conduits had to be used. So they also showed that if a patient has a single segment long saphenous vein, then these patients should get a bypass surgery first rather than angioplasty. But this advantage was lost if another conduit was used instead of long saphenous vein. Soon after, Basel II was published, was presented in May 2023. And that actually confused everybody now. So the Basel II was also a multicentric study. And when they published their results, and we'll go into detail, that they said that the angioplasty treatment first is better than the surgical treatment for patients with CLTI. And they looked at the patients who were treated for below the knee vessels, plus minus if they need any additional above the knee treatment. So they showed that the amputation-free survival and death rate was better in endovascular treatment. So now the vascular fraternity was confused as to what to do. I mean, one trial said level 1 evidence that it is the surgery which is better, whereas Basel II says that no, it is not surgery, it is endovascular. But if you look at their both these trials were prospective trials, randomized, multicentric, and pragmatic. Pragmatic meaning that they were the investigators were allowed to use whatever angioplastic balloons or drug-eluting balloons or drug-eluting. They were not drug-eluting stents. They were not restricted very tightly to what they need to use. But when you look into details of these trials, you find that there are the first and major thing is that their primary endpoints are different, and number 2 is that they have subtle differences which can influence the outcome of these trials. It is very small. I don't think you will be able to read it. I'll just believe me what I would say. And I'm just going through the number. So these are showing that how many patients are recruited. So Best CLI recruited more than 1,400 patients, and then they divided them into 2 cohorts. The one cohort was they did a ultrasound scan and then looked at if the patients have a single segment long saphenous vein, meaning that long saphenous vein from the same side, not from the other side, or not a vein from the arm or other way. So single segment long saphenous vein. If they had that, they go into cohort 1. And if they don't have that, they go into cohort 2, where any conduit other than long saphenous vein could be used. And they then divided into breast surgery and endovascular treatments. And quite a few numbers actually were dropped because some of them, the end of the trial, some of them died and some of them retracted from follow-ups. So after 5 years, about 280 patients were in the surgical arm of the first cohort and 277 in the endovascular arm of the cohort 1. And the cohort 2 had only about 350 and 60 patients, and they were divided equally into two cohorts, two groups, endovascular and surgical. And I would say here that the cohort 2 did not show a lot of difference between the two. So we'll just concentrate on cohort 1, which showed that surgical option was better than endovascular option. Basel 2, on the other hand, had 345 patients, 172 in one arm, 173 in the other arm, and after 4 years, they followed up about 125 patients in each arm, and they showed that endovascular is better than open surgery. Again, I'm just going to go through this. These are the patient characteristics, and the only difference I could pick up which can influence is the age. The Basel 2 patients were 5 years older than the best CLI, and rest of the characteristics remain almost the same. So the result, the primary endpoint of the Basel the best CLI was that major adverse limb event, MEN. So major adverse limb event, they looked at the major adverse limb event during the fall. This is a primary outcome, whereas secondary outcome was death and amputation rates. Whereas the primary outcome in Basel 2 was no amputation, a number of amputation-free survival, which includes amputation and the deaths together. And also they have separated the deaths and major amputation. And this shows graphically the Kaplan-Meier curves, and they show the same thing we've just mentioned. So I'll just summarize what they have said in the two trials. So the cohort 1, there were 1,434 patients, and cohort 2, 396 in best CLI. The median follow-up was 2.7 years, and 72% of the patients were diabetic. Rest pain alone was present in 20%. And the significant tibial disease was 67%. So it is mainly below the knee. The primary endpoint was major adverse limb event or death, and the surgery had 42.6% events, and endovascular has 57.4 events. So surgical bypass was 32% reduction in the major adverse limb events. And this finding was, according to the trial, was driven by twice the number of major reinterventions which happened in endovascular group. Whereas in Basel 2, the number of patients was 345. They also followed the patient for 3.3 years. Again, the diabetics were almost the same number, 70%. They had tissue loss in 90% of the patients, whereas in best CLI it was 80%. And the trial was for below the knee arteries plus minus infrainguinal. And the primary endpoint was amputation-free survival. The amputation-free survival, as I said, includes not only the amputation but also the death. And they show that in surgical arm, and there were 63% major amputations or death, whereas in the endovascular group, there was only 53% major amputations or death. The patients, these are the amputation-free survival, not the. So the surgical bypass was 35% more riskier of major amputation and death. And then, according to them, this finding was driven by the few deaths in the endovascular group. So the patients in the surgical group died more than the endovascular group. So it is confusing to say, which path to take. But then, as I said, that the endpoints are different, and there are other changes in the severity of the disease. It probably is different as well. So they haven't looked at the task classification as to how bad the disease was in these groups. So probably that is one thing which needs to be looked at, and also that the patients have end-stage renal disease or not, because the end-stage renal disease patients do have occlusion or stenosis of the peripheral vessels, and it has been extensively, known and in the vascular groups. So what's the way forward? So the further analysis of the database of BEST CLI and BASIL-2 are required to understand the reason why there are differences observed in these two trials. Individual patient level data and meta-analysis of this data of the two trials will give us some answers, and I think I've met the chief investigators of one of these trials, and then they have already agreed between the two teams that they will pool their data, patient level data, and then look at it as to what is the reason why these patients we had different results. And it will be very interesting to find out as to what is the outcome of this meta-analysis, and this hopefully will pave the way for us to look at as to how to treat these patients for the CLTI. We have already discussed this, that there's no other option, deep venous arterialization, and I won't dwell into this anymore. And one more thing which I have been using in our hospital is intravascular lithotripsy. These are the balloons which we actually, it's a novel approach using pulsatile sonic waves to treat the luminal and medial calcification, and we see this in diabetic patients and the patients with end-stage renal disease, that the distal vessels are very, very calcified. So there was a meta-analysis, and they looked at the 5 different studies with 336 patients, and there was significant reduction in the stenosis after the use of intravascular lithotripsy. There were some complications, but the complications were in the way of 1.2%. There was one, I think, flow-limiting dissection, and there was 1 or 2 perforations, and 1 distal embolization. And you can see this in this the catheter. These are the filament on which which generates the shockwave emitters, and it was started for the coronary arteries by the cardiologist, but now being used for peripheral vessels as well. And we had a very good result. I didn't put any of my figures, but we had 4 or 5 patients and very good results from that. So in conclusion, BEST CLI and BASIL-1 and BASIL-2 have given us level 1 evidence to treat the CLTI. The results of BEST CLI and BASIL-2 are conflicting, obviously, and we will have to wait for the analysis of the pooled data. Until then, I think, I personally feel that we should continue to treat the patients, individual patients, and look at their assess their comorbidities and see what is the best way to treat them, and rely on the MDT decisions as to what is the best way to tackle these CLTI patients. Thank you.
Thank you very much, Dr. Khalid. Very elaborative comparison of two trials. I must say they have given us a level 1 confusion to proceed. I was there at Charing Cross this time when they were presenting this data, and the people who conducted the trial, they were as confused as everybody else. So I would like to know the opinion of experts regarding these two trials, and what is the way forward from here for people who are in practice.
So I think it is confusing, the data, but I think when you think about it, I think that in the real MDT situation, when you look at the images in an MDT, I think it's, you can kind of, it's not all in equipoise. It's often a patient, it'll obviously be more beneficial for them to have a bypass because they may have a very long lesion. We don't just have single lesions, do we? We have multi-level lesions, and often in those situations, the best option is to do, bypass. Whereas, if you've got isolated lesions that are below the knee, that are just tibial vessels, then angioplasty. So I think maybe, for just the SFA, it was a relatively straightforward single lesion that we were treating. Here, we've got multiple lesions, and I think, common sense and MDT decision, and the expertise of the unit, of course, as well, because some units will be better at doing bypasses. Other units will be better at maybe doing angioplasties with a better endovascular service. So I think that one doesn't have to be too confused. I think it's useful to have the data there, and it's quite reassuring to see that best CLI says that vein is, as predicted, is a good conduit for these types of situations. I think taking account of the lesion in the individual patient in an MDT format is definitely a way forward, but using the evidence where we can, but not being dogmatic.
Thank you very much, Dr. Khalid. Moving on, we have Dr. Fahad Tariq Barlas from Karachi, who is online with us on Zoom, and he will be giving a presentation on establishing endovascular services in Pakistan, the challenges faced, and the way forward.
Yeah, Fahad, we can see your screen clear. Yeah, thank you. So you have 15 minutes for your talk, and you can start, please.
Bismillahirrahmanirrahim. Rabbi Shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you, sir, for this opportunity. My regards to all the team, mashallah, that are here. This is a great event, and especially our international team that has come all the way from UK, and also the team that have gone from here. The topic that I've been given today is चैलेंजिंग वन एंड डॉक्टर जिया ने एक और चैलेंज बढ़ा दिया है कि 15 मिनट में खत्म करना है. ठीक है, वैसे सर आपने थोड़ा टाइम ज्यादा दिया था. इसके बाद लंच, इसके बाद खाना है सर. मेरी प्रेजेंटेशन की सबसे अच्छी बात यही है कि इसके बाद खाना है, तो इंशाल्लाह सब एंजॉय करें. तो आई विल ट्राई टू सम अप व्हाट आई थिंक is my understanding of the challenges that we have faced, and inshallah then we'll have the feedback. So bismillahir rahmanir rahim. I have especially mentioned this slide in the fact, अगर slide के अगर नीचे view करें ना, तो I've mentioned that I just don't work in trauma center. I am also associated with SAOT because now we are running a combined vascular surgery program, which alhamdulillah is one of the largest volumes in the whole, I would say, the region. So this is a great achievement in itself, alhamdulillah. So this would be the color coding. I will be discussing the background and the challenge and the way forward. So just going to the background, as we all know that in 1990, Dr. Parodi, with his fellow vascular radiologist, did the first EVAR. However, this was like 2 centuries and down the line from the independence of USA. So Alhamdulillah, now we are sitting here at PAKVESCON. And we would say that the training program, I would believe that was recognized just in 2016. So, Alhamdulillah, we are going at a good pace. And I guess, again, as Dr. Choksi mentioned, that we should all be very proud of this, Alhamdulillah. So we'll catch up, inshallah, and the future is bright. And also sharing with you the videos of the first of the EVAR case that we did. That again is a reflection just of the fact that, alhamdulillah, things are moving in the right direction, and we hope to achieve more soon. So the challenge, if it was easy, then everyone, of course, would have done it. So what I believe is challenge number one. Is it the resources? कि चीज़ें बहुत महंगी हैं, क्या ट्रेनिंग की अपॉर्चुनिटीज नहीं है, या कैथ लैब नहीं है? तो I believe the challenge is a bit different. The challenge number one that I put is having a free mind, and the fact that knowing that you can do it, it will drive you forward. So after that, I would go to the training bit. And in the training, what I would say that I would divided the training aspect into three categories here: the trainers, the training, and the pathway. So the trainers mein kya issue hai? Trainers mein what I believe had been the problem was, number one, were the trainers trained? So again, as we have come across these years, we have seen that a lot of the people that were trained, I believe in UK that was a system as well, that some centers had better endovascular training opportunities rather than others. And probably we should learn from the experience of the cardiac surgeons who didn't ever go into the field of doing endovascular stuff, and then it was just taken out of their hands. So were the trainers adequately trained is a question. And are there the sufficient number of trainers available? Are there training centers that are available to cater the needs of our trainees? So availability issues, I would go to the next, just a picture showing up in a moment. So this was the first Karachi Vascular Week that we did with the Department of Vascular Surgery, Ahsin University. That was in way back in 2018, and we were very, we were obliged to have Dr. Choksi there with us at that time. लेकिन सर पता है क्या, इतने दिन से आपको ना बड़ा मिस किया हमने. तो 2018 के बाद से सर अभी आए ना, तो ज़ाहिर ट्रेनिंग में फर्क तो पड़ेगा. तो अब सर को maybe we should ask our international faculty to have a more regular visit to Pakistan, so that we can definitely learn a lot from them. So as far as the trainees are concerned, I would say that a few points are that the vascular surgery program was never recognized till late 2016. And then there was no structured training. And still, the problem we are facing here is that our younger trainees, the GS trainees, are not exposed to vascular surgery rotation except for a few individual institutions that have in their own capacity allowed their trainees to rotate. This has deprived us of the exposure of these trainees to the field of vascular surgery. They don't know what the things are, and this is extremely frustrating, of course, and this needs to be addressed at a very stronger level. So what about the pathway? The access to a cath lab is a big issue. A lot of programs don't have regular access to it. We have worked on it through CAPSP regulations that all of these units still have some access to the cath labs, and also access to advanced endovascular training programs is something that needs to be worked upon. So funds and resources, big limitation. These inventories are costly, and you know that a simple angiography can range from somewhere to 550,000 with an angioplasty procedure going for many we are around 4 to 5 lakh rupees, which is not affordable, of course, for a majority of the patients. Again, another issue that I want to make a point of, and that needs to be addressed, that the inventory is not available. The companies are there as well with us, and they should be listening. They should now, inshallah, and they will try to make the stock available. You place an order of something and you get it like after 3 months of time. You can't just wait for that much of an inventory to be available after that much of a time on a patient who's having critical ischemia. So this is a big issue, and we need a firm structure and support mechanism with our industry partners. And again, there are maintenance costs associated with it. Disclaimer. This is our turf house, and the first disclaimer is that the next slides to be shown are not my opinion only, but from expert that I've been taken from very reliable resources. So the turf war is a big issue. So what the first thing was you heard is, यार ये तुम्हारा काम ही नहीं है, ये तुम्हारा काम ही नहीं है, तुम्हारा डोमेन ही नहीं है ना, तो ये कहाँ से तुम कहाँ से आ गए? So this is something that I took from a 1989 article by Rutherford. So the non-specialist with cath lab access versus a specialist with a cath lab access. This is his article and says a lot. This diagram says a lot. It needs not much explanation. So Dr. Veeth, according to him, he says that like species in the Darwinian analogy, vascular surgery is now competing with other specialties for the institutional resources or the food and environmental niche, that it needs to provide the best care and to survive. Not only just it tells that we are in the for, however, it also emphasizes the point that we need to be really good in our work to win this war, is even like if there is a war. So for these essentials, then vascular surgery now competes with general and cardiac surgeons as well. Some, especially the fields that is now being shared with interventional cardiologists and other fields, and the people that are doing the same work. So again, similar coordination, because this is again a topic of much debate, that the interest, what drives the interest, again is a topic that needs a lot of discussion. However, a lot of factors need to be considered while considering who does what. And like the amount of training, is this just a simple course that we can do and say, yes, yeah, I am now an endovascular specialist, or what? This needs to be decided. And now, since we have the society in place, I guess this will be a great way forward and much more easier to communicate with other societies as well. So again, a very real life problem is that, as defined by Dr. Zaidmi in his talk, that Pakistan is among the top countries that have the most diabetic burden, and we have patients in number of millions. Of course, you cannot treat them all. So the better strategies would have been prevention strategy, early referral system. So even while living in Karachi, you have to sadly say that the patients that come to you are so late that their disease are so advanced that you cannot salvage these things. And even if you have to, maybe a simple angioplasty would have been sufficient enough procedure for them. However, if they come late, you end up having CTOs, and the cost of inventory goes up, cost of limb salvage goes up, and all these associated factors associated with it. So again, the sixth, I would say, the challenge that I have pointed out, that a lot of data is industry driven, and there are so many devices that this is an excerpt that I took from a journal of vascular and interventional radiology from the Jim Riekers from Amsterdam. Says that when he went to read this one this year, that was in 2019, and then he said that he saw a tsunami of new devices that he had come across. The parameters that these devices were driven by, most of them by the industry. And however, these are an insight to a lot of innovations that can really be helpful down the line, but we really have to choose wisely that for which patient, what device and what option needs to be availed. So again, we are vascular surgeons. Please do not forget that a good femdistal bypass is still considered one of the best options. We have now grade 1, level 1 evidence available to support the data. And so we have to be very meticulous in our choices. These choices are not just driven by the fact that what is available to us, but also by the fact that what is expected of us, what is ethically right, what suits our society, our circumstances, and our resources. So, so what I think the way forward is, and what we have done till now, and what can be looked upon. So again, we need to free the mind, and you have to challenge the horizons. So knowing that yes, you can do it. You have got the knowledge of the disease. You have now got, alhamdulillah, a lot of places that are offering endovascular procedures. There are training mechanisms in place. So all of this is now the dream turning into a reality, alhamdulillah. So just a small statement to make, alhamdulillah, that despite all of these challenges that I mentioned and we faced in the last few years, we have been able to do more than 1,000 of these angiographies, a lot of angioplasties, and the number are still growing. We have all those challenges still in place, and we're trying to cope up with them. And but still, the disease burden, the referral systems are also improving. Inshallah, we hope to see the better. Let's skip that. And again, a big step, alhamdulillah, for our trainees is that now the vascular surgery is the recognized program. What we need to consider is the duration of the training, duration, and probably development of an advanced endovascular program. Once we are through that step, maybe a 2 years training program, I believe, and a lot of other people, that it might just not be sufficient, as the training structures elsewhere are offering much more years. So we have to compete with all the international trainings. So alhamdulillah, one of our consultants is now in Maastricht University, and inshallah, he also has a plan of going to Singapore for 1 year advanced fellowship training. Inshallah, once he come back, and then we can of course learn from him, and of course impart this knowledge and start some sort of vascular training that that takes you to the next level, inshallah. So dedicated cath lab. So this is our cath lab, alhamdulillah, and this is totally arranged from donation, alhamdulillah, and this is available 24/7 to us, and the upcoming is also, inshallah, a hybrid theater for the vascular team, and all the units are welcome. We also have a mechanism in place. Inshallah, we are welcoming trainees from all over the Pakistan, inshallah, once we get all this in a regulated fashion. So just a picture of our team. Sir always is our pride, and with all the team around him. So, and instead of turf war, as again one of our speakers mentioned, that collaboration is the key. So alhamdulillah, we are already doing that with our IR department, our team with SAUT, AKUH, our group from UK, USA. Also now we have Turkey and Maastricht on board again. So the horizons and future is very bright, inshallah. So alhamdulillah, we have this disease-free awareness program, amputation-free sin approved by the government. And by this, we are going to spread and start an awareness program, inshallah, as well as we are going to have a hybrid theater, which would serve a lot of our purpose, inshallah. So I believe that maybe you have been introduced to this, the NEST, through collaboration with Medinostics and Sanofi Aventis. We have acquired we have developed this idea of developing a national endovascular simulation based training, where a simulator would be available to all our trainees, especially to those that do not or sometimes have limited access, especially to advanced procedures. I guess that would be a great step forward. So National Vascular Registry, sir, we in a few years back also have published an article in JPMA that we have mentioned about the need for a national vascular registry. Definitely, it's one of the most needed things of the time. And so my dream, one of my other dreams would be to establish, to take our training to such a level that inshallah in a few years time we'll be doing those separate fellowships in aortic, venous and malformation works. One of the dreams that I have, inshallah. And of course, our enhanced national and international collaboration with different societies and members from all over the world. So in the end, I would like to quote our dear Sufi's, Dr. Sufi's training, the words he taught us in our training, that please treat the patient and not the x-rays. And I guess this sums my presentation. Thank you so much all for listening. Thank you so much. Sorry.
Yeah, Fahad, you have actually given a very, very great summary of your vision, challenges, and the way forward. That was an excellent talk, and I respect your future dreams, and we are all with you. There are a lot of people who have the same vision, same mission, and you have a lot of friends. I open the discussion because this is very important. We can have few comments or questions if there is any. Yeah. I suppose people want dinner.
Of course.
Okay. So we want to business meeting, and inshallah we'll keep you updated. Stay with us tomorrow also. And this, Mr. Choksi has a comment. Yeah.
1200 USAs, 800 angioplasties, setting up the services that you have, and having that forward vision, I think is really important. And I think that what we must, obviously not we, but I think together, all of us, is see how we can do it in a coordinated fashion. Because when something is new, people often will dash in all different directions and try to do lots of different things. I think having a coordinated approach is really useful. And I think it's really important that what we have to bear in mind also is that, as you've said, is that we need to tackle the simple things really, where it could really make a difference. I mean, for example, you mentioned about general surgeons not doing much vascular surgery. I think actually they should it'll be quite useful for them to do them in the remote areas, in the remote areas of Northwest Frontier and places like that, where there may be a very, very sparse population. And if we were to sort of, what the mission really is to try to provide a level of vascular service for the whole population and give equal access. And I think if that can be one of the missions of the society, I think that would be really, really good. Although, of course, the more advanced stuff can be done in the bigger centers like Karachi and Lahore, Islamabad and Rawalpindi and other places as well. But I think really it would be really good to have that vision, an overall vision of what the country needs and what the needs are. And often it's very basic stuff, the recognition of the disease, the initial treatment, statin use of antiplatelet agents, a lot of it is primary care. And then the very basic sort of management of patients with ischemic legs, even if it's to refer, the recognition of an ischemic leg, when to refer it, what basic stuff to do, like heparin. So I think that this is all stuff that, is really encouraging, mashallah, and hopefully it can be done in a coordinated fashion. Well done.
Thank you, Fahad. So for the sake of time, because we have a business meeting, otherwise this is very important discussion. So we finished that today. And thank you for staying with us. And now we have to go for the business meeting, and trainees will stay here. Thank you. Thank you for the chairs.